Briefly, I'm going to speak a little bit about my experiences, quite limited at this point in time with COVID, and recently had two case studies, or rather a case study published about my experiences with a false positive dengue case that turned out to be COVID. And so I'm going to start off my presentation with a short background. I'll run through microscopically the two case studies and what are the learning points that we can gain from them, in particular as we deal with the COVID-19 outbreak and then with the upcoming dengue outbreak that is, has already been affecting Singapore, as we know. And so I'll start off with my first patient, whom I manage. He essentially is a 57-year-old gentleman, no drug history or drug allergies and no significant past medical history, and essentially a very well gentleman. He came to my hospital, or rather he came to another hospital first, presenting with a 3-day history of fever, and he had a slight dry cough that had resolved by the time he presented to the emergency department. He wasn't breathless, he had no sick contacts or any travel history, and he lived in a dengue hotspot area, as most of Singapore is. When examination was done on him, there was nothing particularly significant. He wasn't febrile, his blood pressure and his heart rate were fine, his lungs were clear, he was otherwise quite well actually. These were the bloods that were taken when he presented to the emergency department on that day, and noticeably you can see that he had a slightly lowered platelet count. And because of that, a dengue rapid diagnostic test was performed, and all of which turned out to be negative. He wasn't suspected to have COVID, but a chest x-ray was done, which proved to be quite unremarkable. And he was subsequently discharged with some return advice. Moving on, he then presented himself to two primary healthcare facilities over 2 days. And as you can see, on day 5 and day 6 of his illness, he had worsening of his platelet counts, and he had developed a new onset lymphopenia as well. On the 6th day of his illness, he was still persistently febrile, and because of the worsening platelet levels, they repeated another dengue test, and this time serologically the IgM and the IgG for the dengue turned positive. And this made it highly suspicious that he had dengue fever. But once again, he was otherwise quite well and was given a return appointment to the polyclinic or the primary healthcare facility in Singapore. But what was unusual was that he really felt unwell on the 7th day of his illness, and he went to the hospital instead, of which they found that his platelet counts had recovered a little bit. He continued to be lymphopenic. And this time round, they repeated another chest radiograph, which is, you can see on the right side, day 7 of his illness. And this time round, on the right lower zone of his chest radiograph, you can see that there's a new consolidation. And this time, the treating physician sent off a SARS-CoV PCR, which turned positive instead. I'm going to leave this case here for now, or rather, I'll just quickly run through what was further done again. So looking at the dengue serology that was performed, on day 3 of his illness, you can see that they were all negative. On day 6, when he presented the second time to the primary healthcare facility with a different dengue kit, serologically, the IgM and the IgG for dengue turned positive. When we had found out that he had SARS-CoV-2 or COVID-19, we looked back on his blood test and extracted the blood out, and this time tested it with a different kit for dengue, and it turned negative. Additional blood test was performed to look for dengue, chikungunya, and Zika through a PCR, and this was all negative as well. And so we we decided that his day 6 blood test performed at the primary healthcare facility was likely to be a false positive dengue serology test. Moving on to our second patient. Similarly, a 57-year-old lady with no known drug allergies, and she had no significant past medical history, and a non-smoker as well. So a really similar background to our first patient. She came into the hospital emergency department, and similarly, she had fever, giddiness, muscle aches, and a mild cough for 4 days in duration, and 2 days prior had started to develop watery diarrhea. She had no sick contact or travel history, and similarly as well, she lived in a dengue hotspot. Noticeably, she had a fever of 38.8 degrees Celsius, but otherwise her blood pressure and her heart rate and her saturations were unremarkable. She was not tachypneic, she was well, and auscultation of her lungs were clear. As you can see here, the labs performed on day 4 of her illness, which was the first day that she presented to the emergency department. She was noticeably thrombocytopenic with a low platelet count of 92. And a dengue test was performed, and this time round, the dengue IgM was positive. Chest radiograph performed was also unremarkable, no consolidation seen. She was discharged with a diagnosis of dengue fever with no complications and given return advice. She represented again to the emergency department 2 days later because of persistent fever. This time round, she had worsening of a thrombocytopenia, and she was lymphopenic as well with an absolute lymphocyte count of 0.94. Noticeably, she had transaminitis as well, an ALT of 67 and an AST of 69. She was actually kept in the general ward, and throughout the length of her stay up to day 9, she had worsening of a thrombocytopenia, she had worsening of transaminitis, and on day 9, she became dyspneic, and the treating physician heard crepitations in the lungs on auscultation. This time round, they repeated a dengue serology and found that actually the dengue IgM was negative, and the convalescent IgG for dengue was negative as well. And so this made it very suspicious. They repeated a chest radiograph for her, and as you can see, this time around in her upper lobes on the right side, there are new infiltrates. And so they sent off a nasopharyngeal swab, and she was positive for COVID-19. And so once again, we dug back. This time around, both kits were the same, the SD BioLine kit. We extracted blood from day 5 of her illness, and for dengue PCR, it turned negative. And so similarly, we called her dengue IgM on the first blood test a false positive dengue IgM. So I'm going to move on to a few learning points. I'm going to speak about the length of stay of the patients. Now, firstly, dengue, as you can see here on a map provided by the World Health Organization, is quite rampant throughout the world. In Singapore itself, on the right side, we have nearly up to 20,000 in 2013, which was the peak of dengue cases. And last year itself, in 2019, in Singapore, we had 16,000 cases of dengue and up to 20 deaths. In the last few years, the major serotype for dengue in Singapore is type 2. And in this year, in 2020, in Singapore alone, we have had 4,000 cases already. We are nearly seeing about 300 to 400 cases of dengue a week. And we have seen a rise in dengue serotype 2 this year. I'd like to show this coronavirus epidemiological website from Johns Hopkins. Essentially, this is the latest update at 7:30 p.m. 480,000 confirmed, of which we have had 22,000 deaths and 115,000 that have recovered. In Singapore alone, we have had 560 cases. That was yesterday at 12 noon, and they haven't been updated yet, but it's definitely increasing, of which 2/3 are imported from overseas. So 1/3 is locally transmitted. And as you can see right at the bottom of my screen, our Ministry of Health has identified nearly 9,000 close contacts who have already been quarantined. And of these, 2,600 are still currently quarantined, and the rest have finished their quarantine. So there's a lot of infection control, public health measures that are put in place outside of the hospital setting. Now, I'm going to run through a few clinical features of COVID-19 and dengue, and in the middle here we can see where they have similar clinical features. So COVID-19 is a respiratory viral illness. So essentially they have cough, sore throat, they may be breathless on presentation, and some people have a runny nose. On dengue itself, they typically have a rash, they may have some joint pains, may have some pain at the back of the eyes, some abdominal pain, bone pain, bleeding. But they both have similar features in that they both have fever, they both may have some muscle aches. Headache is quite a dominant feature, but usually that is with the fever. And they both rarely have diarrhea as well. And in the laboratory setting, as you can see from my two cases presented, they have features of thrombocytopenia, leukopenia, and transaminitis. And actually looking back at the data from China, published in the NEJM paper and in the Lancet as well, we tend to see people who have thrombocytopenia, leukopenia, transaminitis in the sicker cases of COVID-19. So this is one of the risk factors for severity as well. Briefly, I want to run through the dengue diagnostics and how our rapid dengue diagnostics can be interpreted. So primary dengue infection is when you first get infected with dengue. The NS1 and the IgM start to rise up initially, and then subsequently at about day 6, 7, the IgG starts to rise up. Whereas in secondary dengue infection, the IgG is present right from the start, and the duration that the NS1 as well as the IgM that remain in the blood is of a shorter duration. And so you can see that in all diagnostic tests, they have their own sensitivity and specificity issues. I'm just going to focus a little bit on the dengue diagnostic tests, and in particular the NS1 antigen as well as the IgM. For the dengue NS1 antigen, false positive results can be gotten from other flaviviruses. So in particular Zika virus, which was what we were seeing back in 2018 here in Singapore when there was the Zika outbreak. And there has been published cases of hematological malignancies that cause false positive dengue NS1 antigen results as well. In terms of dengue IgM, similarly, other flaviviruses can cause a false positive result. Malaria, and now we can see SARS-CoV-2 as well, can cause false positive results. And on the other side, we have false negative results from the dengue rapid tests, and in particular, we have seen it in our serotypes 2 and 4. And for both the NS1 and the IgM, they can be falsely negative in secondary dengue. So these are just a few take-home points to note when you're looking at the dengue tests, and if the clinical picture does not fit your diagnostic tests, then you need to revise your clinical decision and your differential diagnosis, which was what happened in this case. I'm going to speak a little bit about the COVID experience in Singapore and what has worked for us. Mainly, what we have done is scale up our diagnostic capabilities. We have done thousands of swabs a day. The labs are working round the clock. We have increased our bed capacities, especially in terms of the isolation facilities. whether in the general wards as well as in our ICUs. We're all well prepared for that. Singapore itself has a wonderful contact tracing team led by the MOH, and recently we have just come up with this app for us to help trace and any people who have been exposed to COVID patients. And finally, I'd like to highlight about our leadership, led by our Prime Minister Lee. Essentially, the message from the top has been very clear, and this has translated down to the ground. And essentially, if everyone has been paying attention to the news, and you noted that he spoke about how we should not be rushing to the supermarkets to buy toilet papers and not to hot goods and all that, and that had a profound effect on the population. And so that has helped to calm our nerves in this time of a paranoia. Well, other than what the healthcare facility can do, what the government can do, everyone else plays a part. So I can't emphasize enough that you should either stay home if you can, or if you're going out, keep a distance, and otherwise wash your hands and don't touch your face. I'm going to talk a little bit about managing dengue in this time of corona, as I'm appreciative of the fact that many countries are going to experience a COVID-19 outbreak together with a dengue outbreak, and what are some of the things that my hospital has done to help with managing this pandemic. So in my hospital in NUH, we have a dengue outpatient management clinic. This is a very protocol driven and is led by the nurses, and it essentially saves off bed space for patients to be managed in an outpatient setting. They can have drips, intravenous fluids given to them there. They have their blood tests there, and if they meet certain criteria, they can be discharged. If there's any problems, it can be escalated to the doctors. And in the wards itself, we have very short stay units with a turnaround time of 24 to 48 hours if the patient cannot care for them. Most of our dengue cases are actually managed by our well-trained internists, and if necessary, they would get the infectious disease teams on board. Finally, I just want to highlight that infection control management of dengue and COVID are absolutely on different ends of the scale. Dengue is managed with standard precautions. Just make sure you wash your hands before you touch the patient and after you touch your patient. But in terms of COVID, especially when symptoms are so vague, we have started to wear our full PPE. So a visor, an N95 mask, a full gown with gloves as well. So it's very important to hopefully be able to distinguish from a patient's clinical presentation, and this can help you appropriately send the patient to a airborne precaution room or a standard precaution bed. So in summary, I'm going to wrap it up. I highlight that COVID-19 and dengue share many common clinical and laboratory characteristics. It's found that SARS-CoV-2 can cause a false positive dengue IgM. And to take note that all laboratory tests have specificity and sensitivity issues, and investigations make up only one small part of a patient's assessment. And with that, you have to be aware of anchoring biases. So don't be fixated on the first diagnosis that you get, but continue to make regular assessment of the patient and be not afraid to alter it if you think something is not right. Finally, there's a call, and definitely a huge one, for the urgent need for sensitive and specific tests for dengue. And similarly for COVID-19 as well, we need quicker point of care testing as well for COVID-19. And finally, to highlight, in the midst of preparing for a dengue outbreak during COVID-19, I can't stress enough that infection control is paramount. And with that, I'd like to thank this wonderful team that I worked with. They include lab members, they include the fellow clinicians that I've worked with, and other hospital members as well. And I'm happy to have any questions now. Thank you.
Thank you very much, Gabriel. I think there's a global round of applause for your presentation. It's a bit disconcerting here on my own in my living room. Thank you very much. I think your message was loud and clear. Lots of good advice. It could be a really defining moment as well for the diagnostics that you mentioned. Maybe an opportunity for CRISPR-based solutions to kind of come to light. But of course, with the also many issues about scaling up all the diagnostics, so perhaps something we can talk about in a few moments. You've had a few questions. I don't know if the chat is coming up on your screen,
Yep.
but I think the very first question, I mean, we're delighted to have Dr. Srimanta Parida who have joined us, infectious disease clinician from India. I think, Dr. Parida, you're now currently in Berlin, but I may be wrong. So Dr. Parida's question is, has further molecular characterization of sera of these two patients been ongoing now? And any lead or early indication of cross-reactivity in epitopes or binding?
I'm afraid I don't think we are doing any molecular characterization of the sera at this point in time. There are many research studies ongoing. I'm afraid I'm not privy to it. Yeah, so I'm more of a clinician than a research doctor. So I'm afraid I can't really answer this question. My thoughts on why the IgM turned positive is just a feature of the test. Dengue serology test is notoriously known to be not a very sensitive test, and they range from 50 to 60% sensitivity, especially for the NS1 and the IgM. So yes, yeah, I'm afraid that's the best answer I can come up with.
Brilliant. Louis Macareo, is there any estimate on how frequently dengue IgM can be made false positive by COVID, and any ideas why there is this cross-reactivity?
Okay, so in Singapore, to my knowledge, so far we have had 3 dengue tests that were falsely positive for the IgM. I'm not too sure how the other hospitals are, but I presented 2 of the 3 cases. We're not testing everyone for dengue, so I'm not too sure what are the false positivity rates, I'm afraid. Yes, and any idea why there is this cross reactivity? Once again, the sensitivity of the kit. Some of these COVID patients that we have seen, in particular the sicker ones, they go into a cytokine storm. I'm not too sure whether that is a form of a trigger for the false positive dengue IgM.
Helena Uliartha, Dr. Yan. And by the way, Gabriel, there's been a lot of people saying thank you and congratulations for a very good presentation. So lots of positive feedback. So from Helena, Dr. Yan, do you use a rapid test for SARS-CoV, and did you use it for SARS-CoV in Singapore? If yes, what rapid test did your country use? And what do you think the role of rapid tests so far in a pandemic setting? That's what might...
Okay. Currently in Singapore, we don't have any rapid tests ongoing. What we have used in my hospital was a lab-developed test, and similarly for all the other hospitals as well, if I can speak for them. Currently, there are many rapid tests that are being validated as they come in from the market. Ideally, we would want one of them to come on soon, and there are many reasons. We are running out of reagents. We are running out of potentially swabs. We are running out of yeah, I mean, it's impossible to do so many PCRs a day, and you need to ramp up with the machines and all that. So a rapid kit would be very, very useful, definitely. Our current turnaround time for a swab is about 6 hours once we have received it. So a rapid test would have a result, hopefully within 15 to 30 minutes, and that would help with saving bed space, that would help ease nurse for the patients. And this will help to drive down costs, definitely. Yeah. So unfortunately, we don't have a rapid test at the moment, and we hope one could come up on the market soon.
Well, we just had a reply again on the chat, and I must apologize. Hopefully, next time we'll be able to have participants actually participate live. With your permission, of course, we don't want to beam anyone in their pajamas against their will to the rest of the world. But anyway, in the meantime, Dr. Pereda has replied saying, as you know, the day before yesterday, Mesa Biotech in California has had their point of care test for SARS-CoV-2 approved by FDA, and this can be rolled out swiftly with results in 30 minutes in every location with a handheld device. So there's quite a substantial, piece of news there.
Excellent. I can't wait to see it in Singapore.
Yeah, and so it is 1:30 now, our time. So our webinar has reached the 30-minute mark, but perhaps we could have one very last question, which I think as a clinician would be great to ask you, from Jose Moreira, who says, thank you for the presentation. And based on these observations, would you recommend regular screening for dengue in patients with suspicion of COVID-19?
Okay. I wouldn't use a dengue screen to look for false positive IgM to help with the diagnosis of COVID. I mean, I was asked that because the dengue rapid diagnostic kit gives you an answer very quickly, and if you're not if you don't have the facilities for PCR to be done for COVID, then you're just wondering whether a dengue rapid test might be used, and I don't agree with that. Essentially, it would just bring up more questions to be asked, whether the patient now has dengue or does he have COVID. So that was the use of the test, a dengue test to diagnose COVID. Now, whether I would do regular screening of dengue for patients with a suspicion of COVID, I think I would go clinical. It definitely makes sense to make sure that your patient isn't co-infected. There have been a few cases that have been reported, similarly in Thailand and in Singapore as well. And it helps because in dengue, you do see, they have their febrile phase and then they have the critical phase, which is seen from day 3 and nearly up to day 10. And it can be quite a different scenario to manage. In our COVID patients, they tend to turn sick from day 7 to day 14 of their illness. And so in dengue, you see them turn sicker earlier. And definitely it would be good, especially if you're suspicious of dengue, to screen for dengue. Now, what I've learned from these 2 cases is that they had a persistent drop in their platelet count whilst they continued to be febrile, which is not something usually seen in our dengue patients. Our dengue patients tend to have lysis of their fever, is what we call. Once once the fever lyses, the platelet count starts to drop. Whereas these patients, their platelet counts drop and the fever persisted. So that's something that did not fit the textbook picture of dengue. So with this little fine tune, you may be able to separate it and decide whether you may want to additionally test for dengue and additionally test for COVID. Now, saying that, one final point is that 30% of COVID-19 patients and up to 50% who are sick are known to have thrombocytopenia and leukopenia as well. And in such patients, definitely it's worth checking for dengue in them. I hope that helps to answer the question.
Thank you, certainly. Gabriel, there's been a lot more questions. However, I do realize you've just come off a long shift at the hospital as well. So at the same time, I'm sure some of our participants are quite happy to carry on with 1 or 2 more questions, but it's really up to you. We don't want to hold you for too long. So if there's any question that you maybe see, would like to answer, please do go ahead. I'm personally in no rush to end the call, but it is really in your hands.
Okay, I can probably take about 10 more minutes of questions.
Okay, well, that's very kind of you. Thank you. Perhaps we could combine as well the question from Mohammed Bilal and Dora's question further up the chat. So as the COVID-19 and dengue have common symptoms, what diagnostics to do first in the patient? And
in COVID-19 patients, what tests to perform first? So in my hospital, depending on how they present, some of them, especially our young COVID-19 patients, they present with a very mild upper respiratory tract infection. maybe a runny nose and a bit of sore throat, and actually they don't have any fever. And because they are young, they are in their 20s and in their 30s, we don't do many laboratory tests. Uh, so we just swab them actually, and if they are febrile, then we may perform a basic full blood count and maybe a chest radiograph as well. In our elderly population, or rather in the middle age and elderly patients, that's when we do a little bit more tests. What has been quite good prognostic things are like a raised LDH, as well as lymphopenia. These have been soft signs of COVID-19 in patients, and a chest radiograph as well. That may help to push you towards getting a diagnosis of COVID-19. Then we have our sick COVID-19 patients, and what are the tests that show that they are quite sick? They have elevated C-reactive protein, which is not particularly seen in viral illnesses. They have elevated ferritin levels, and once again, the lactate dehydrogenase levels are quite high as well. So these are some tests that we have utilized to help to prognosticate how their disease is going.
We do have a very important question from Jacob Kojima. For low-income countries who do not possess all of these exams, in an African context, for example, where hospitals are not well equipped, how can we ensure a good diagnosis and a good management if such a case occurs?
Okay. So I mean, the gold standard is a nasal pharyngeal swab or sputum that you get the diagnosis of SARS-CoV through a PCR. And I believe that in the UK, they're not really doing that for many patients, and similarly in the States at this point in time. And what they have done is, unfortunately, you have to triage such patients. Okay, so firstly, you have to be suspicious of COVID-19. They have a respiratory illness. They may have been in contact with someone with COVID. They may have returned from somewhere with an outbreak of COVID, and that immediately ramps up your worry of them having COVID. And then you triage them to see are they well, do they need to be admitted into the hospital. And I believe the message is that if you're well, you may be able to self-contain and isolate at home, but that's not what we're doing in Singapore. In Singapore, we do a swab and we send you home. But I believe for other countries, and even in the UK and the States, they ask you to quarantine yourself at home for the next 14 days and don't come to the hospital unless you're unwell. So that is on the diagnostic point of view. And if you're not, and if these PCRs are not so widely available, then you have to just go clinical. And now, who are the ones that potentially need to be admitted into the hospital? Are the elderly ones, or those who have comorbids, those who have cardiovascular illnesses, those who have diabetes, those who have a primary lung problem as well. And these people may need to be watched in the hospital and to monitor how their symptoms progress. And essentially, once again, to take note that these patients tend to turn unwell in the second week of their illness. Finally, to protect the hospital and prevent nosocomial spread, you need to keep them in an appropriately isolated room with airborne precautions.
Brilliant. Okay, so perhaps our very, very last question. Catherine Brown, based upon the clinical features you have observed, is there any suspicion of the co-infection with other pathogens beside dengue virus? And maybe looking, further, are there in COVID patients in Singapore, in dengue endemic regions, are there certain infections you are particularly wary of?
I mean, at least in Singapore, what we have seen for some of our COVID patients, they have other respiratory illnesses as well. So if you do a respiratory multiplex and you do pick up other respiratory viruses, then you should not stop there. You should still be on the hunt for COVID-19, because we have seen quite a few of these co-infections as well. And then in Singapore, we have other things that can have that can mimic dengue or influenza, and these things are like Salmonella typhi, also typhoid fever, and sometimes we have our rickettsia diseases as well. So yes, they may have a little bit of a similar presentation with thrombocytopenia, fever, and you need to be on the lookout for these patients. But they may not have any respiratory symptoms.
And Helena Uliartha was agreeing with you there. Yes, good point, and agree that if clinical features meet, and even if the PCR is not positive, just do the isolation anyway.
Yes.
Okay.
Yes.
Well, Gabriel, thank you so much. I think you've made history here, giving a webinar straight off the front line, while a large part of the world is in isolation, in lockdown. You've been beamed into our homes and our living rooms, so thank you very much.
Thank you for having me.
Just like to say a very warm goodbye to you and a thank you, and a final little shout out to Sarang Park, Julian Bobbis, Dora Rogenson, Deborah Kajaguka, Margaret Lufong. Thank you for coming, everyone. Lovely to meet up with all of you. And if you have any more questions for Dr. Yan, please email them into info@isntd.org, and we'll make sure that everyone remains connected. And with that, I'm going to end our first ISNTD Connect, and hopefully see you next Tuesday for our second one. Thank you, and goodbye, everybody. Bye-bye, Gabriel.
Thank you.
Bye. Thanks a lot.
Bye-bye.
Bye.